On the one hand, the COVID has provided an opportunity, actually, to really meaningfully become creative and rethink what we're doing and the way we deliver.
We really need to sort of understand why is it that there is a huge impact on certain communities, and what can we do?
The ONS data says that BAME communities are 4 times more likely to be affected by or to die from COVID.
We always have to be careful on this discussion, because when we say BME, we don't just mean people with black and brown faces. It goes right across the board. And of course, these days, 1 in 10 couples are actually married to people of different cultures.
We're not a homogenous group. You know, we are people belong to different communities, just like the white community belongs to different communities, either Irish, Scottish, Welsh, or whatever it is.
What COVID did was really highlight the huge health inequalities that exist already. I think if we begin to look at just the ethnic profile of our communities without looking at all the other socioeconomic areas, we really are not going to be able to address the needs of our communities. So if you look, for example, in Brent, you have some of the most deprived wards in London and in the country.
The kind of job people from the BMU community are doing definitely put them at risk, because we have a significant number of our services who are living in overcrowdedness or in small flats, suffering deprivation, low income, living in benefit, big families, generation living in one flat. We try to be in touch with them, hear their worries. We have emotional well-being support services. We refer them there to receive to have just someone to speak to.
We are getting a lot of calls from people who are very anxious, especially when they're hearing things about COVID having a big impact in Brent. So there is a lot of concern, there's a lot of anxiety, and people wanting that emotional support.
There are so many small communities, you know, neighbourhoods and small groups of people getting together to support their communities with no funding or support whatsoever.
We're escalating and amplifying the voices of the self-organised communities, which are particularly the mutual aid groups that are really active at this moment in time, but supporting the infrastructure, making sure those other marginalised groups' voices are amplified. And we're doing a lot of work behind the scene, ensuring that the various structures, particularly the council, etc., are listening and hearing the voices from the smaller groups.
We are seeing that communities, specifically people from various minority backgrounds, are connecting with other communities also from minority backgrounds. And we're trying to map this at the moment, but there is something about this whole how communities connect. We've seen it globally, and we are now also seeing it locally. And we know this happens, but it'd be really interesting to understand why it happens, how it happens.
We are happy to be working with other partners, but we really need to sort of understand what can we do to make sure with the second phase, we've actually done something to make sure we are looking and addressing that it doesn't happen to this effect.
If we have a social prescribing system, they need to recognise it and broaden the scope to recognise these unsung heroes and volunteers in the community who are actually keeping people away from hospital, alive, well.
I hope that the politicians and the local MPs will actually go and talk to the grassroots. I think if the politicians went on strike, I don't think it would matter. But if our voluntary sector went on strike, I think we would all be paralyzed.